Well, welcome everyone. This is Tom Judd. I have the privilege of chairing the IFMBE Clinical Engineering Division, putting on our webinar today. I assume all can hear me. And just a couple of brief items as we introduce. First of all, this is our first monthly webinar in 2020, and we'll have them every month on the fourth Thursdays at 11 a.m. New York time. And hopefully, of course, the recordings will be able to be used all around the world, as this may not work for everybody, the time. We're delighted that over 300 folks, colleagues, signed up to attend today. And we've got two wonderful, young, experienced clinical engineers presenting. When I was 29, I'd been in the Navy and started out my clinical engineering career. These guys have a full resume already by the time they were 29, so this is going to be fun. Take it away, Luis and Jennifer.
Thank you very much, Tom. Glad to hear those words of introduction. I'm here today with my friend Jennifer to talk to you about a really, really important subject called HTM Indicators and Stakeholder Management, which is something that we've been talking about for a while, about how we should measure the efforts of the clinical engineering department and clinical engineering as well. And also, not only which indicators should we be producing, but also how should we interpreting those results and those metrics to the people that want to hear it. So briefly, I will introduce my colleague here, Jennifer, which is a really talented biomedical engineer. She was named 2019 headliner for Women's to Watch in 2019 Beyond by BIS Women. She's AME Young Professional for 2016, Technicians Professional of the Year of 2016, and Resident Regional Director of Health Technology Services, Compass One Healthcare at UC Health. So welcome, Jennifer, and take it away.
Thank you, Luis. I am really excited to be here with you all and talk about indicators, and I'm so thrilled that we're starting off the beginning of our webinar series as well with so many of you from across the world. So welcome and thank you so much. I'm going to briefly introduce, hold on, sorry, I'm having a hard time moving this forward. Luis as well. So Luis is a man that needs no introduction, very talented entrepreneurial clinical engineer. He has a biomedical engineering and business background, and he is currently the CEO of a CMMS company and really doing a lot of amazing things in South America and beyond. And all of the content that IFMBE gives you on a daily basis, Luis is really the driving force behind that. So I'm very excited to be sharing with you. I'm going to be talking through indicators, and then Luis is really going to be hitting home with how we're integrating our stakeholders, and then we'll have time for question and answers in between. All right, so a little bit about HTM indicators. So really the precipice of this is one of the IFMBE CED's challenges with the World Health Organization. So this was challenge number 5 in 2019 that the CED group was working to establish. And the idea is that we're going to create recommendations for biomedical engineers, technicians, and other personnel for the type of equipment that a hospital has, how many beds they have, really thinking through a staffing model, essentially, as well as key indicators that will help us gauge what we're doing as a community and the importance of that. So one of the key considerations for this is obviously the stratification of information from high-income countries as well as low and middle-income countries. So there's a lot to consider as we pull all of these things together. Why is this important? Why is it important that we understand the capacity we need to build for clinical engineering moving forward, and why is it important that we need to look at these indicators and share them with others? I've included on the screen some resources from the IFMBE site, including a blog from Tom, the chair of the CED, which you heard give a quick introduction of our webinar series, as well as really our project charter of what this looks like and how we're tackling this problem as a global community and with IFMBE CED really driving. So the importance and the important drivers behind it from a WHO standpoint are really the Sustainable Development Goal 3, which many of you are familiar with, really health and well-being for all. That's why we're all here. That's why we all do what we do every day, driving health outcomes, making sure that equipment is safe for patients and available for them when they need it, to really support not only treatment, but proactive prevention. Also, the triple billion goals. Some of you may be slightly less familiar with this. This is really a newer goal from the World Health Organization. They have 3 goals that 1 billion people worldwide, you know, it's kind of a great grand goal, that 1 billion people will have greater access to care, have better health and well-being, and also are able to have a better quality of life. So all of this, clinical engineers and biomedical engineering technicians are really facilitators of this and making sure that providers have this equipment at the ready and that the right equipment's there so that we can address community health items. One of the other things is we really need to increase the evidence for the HTM community. Many of you were likely at the International Congress in Rome this past October, and 1,000 of us got together from 6 continents and probably 80+ countries, and we shared a lot of great information. But one of the things that we are not as good at, I guess, or we fail to do globally is provide ourselves a platform where we can share our information and share our data with one another. So while a lot of us are doing amazing things in our scope or sphere of influence, we aren't bringing that all together. Obviously, the IFMBE has the Global Clinical Engineering Journal, which gives us that avenue. But one of the things that we also need to do within these indicators is provide some evidence behind what we do. Our clinical providers have to use evidence-based practices in what they do. So things that there's tangible evidence, if we do this and we do it in a reliable way, we will have this outcome. So that's one of the main goals of also getting these indicators out, is establishing clear metrics and clear evidence for what we can do, that we can proliferate and really share best practices and not have to reinvent the wheel regionally or in every country, but also be able to measure our impact and ultimately patient safety. For staffing, one of the big drivers behind this is Adriana's work with the International Labor Organization. So much of our data, as you guys mostly know, or it's available on the WHO website as well as IFMBE, there was a study done in 2018, which really drilled down to the country level. So countries were able to say how many biomedical engineering technicians they had, as well as clinical engineers. But what wasn't able to translate was how does that translate to a single hospital or an organization, and how many biomedical engineering technicians and clinical engineers does a local hospital need to really run proficiently. So we need to build some evidence and build a body of practice around that so we can start to answer that question in a more granular way. And then also creation of indicators around CE. We really have a good body of evidence with the Book of Knowledge that IFMBE publishes, but also we need to dig down into these indicators to determine which ones are the most important for us globally, as well as the definitions behind them and how we're going to be able to mine that data. Okay, so some of you at this point may be saying, what is an HTM indicator? I'm hearing this word and I'm not quite sure what it means. So many of us have different words for this. We might call this a key performance indicator. We might call this a metric. We might call this a balanced scorecard. So really the idea is This is an indicator that we can use with a clearly defined way that we're reaching it, and that we can compare apples to apples programs, as well as regions, countries, and nationally, how each program is doing and the impact we're having. Some of these that you may be familiar with would be preventive maintenance completion, corrective maintenance completion, response time, time to initial intervention, as well as overall turnaround time of corrective maintenance work orders. If you're in maybe some of the more advanced or more mature programs, you may also be looking into your medical device server patching completion, number of cybersecurity threats, and items like that. So why are these useful? These really give us a great idea on a global level of how we're doing. It also provides an avenue and a platform for us to really change the way we're talking about clinical engineering globally. So many of you know that our field, of course, is the best kept secret in healthcare. So many people don't know what we do. It's also sometimes hard for us to translate our technological speak to an administrator or our leadership in our governments and at the ministries of health and really say, this is what we do, this is the impact we have. So by developing these indicators, we not only establish standards for ourselves, but we also establish a strong platform for which we're going to be able to communicate this globally. So with our local leadership, with our national leadership, and at the international level, at the WHO level. So how can you use these? I think probably everyone on this call has success stories of how they've used data and how they've used indicators to increase their resources or provide a solution to a specific problem in an innovative way within their healthcare organization. So again, we have a lot of these local stories. So whether it's we saved the hospital $200,000, or we intervened and we reduced our use errors by a certain amount, which made our equipment more available, or we increased our equipment uptime, to 99.2%. We have a lot of stories and anecdotes at the local as well as national level, but our goal is to get these out globally. So how do we create a success story around clinical engineering, providing evidence and documentation of it globally? So this is really where we need your help. So when I look at staffing, the primary, I'm going to split this into two parts. Staffing is then indicators in the traditional sense of metrics. And Adriana Velasquez from the WHO, she said something very interesting to me that's kind of stuck in my mind. She said, if you have a plane, whether it has 10 seats or 500 seats, you still need a pilot. And that's how we feel about biomedical engineering. So you might have a 10-bed hospital, but that still means you need a clinical engineering professional. You might have a 500-bed hospital and you may have different skill sets, but you still need clinical engineering professionals in that capacity to facilitate continuity of operations. So when I think of staffing, I think of my pilot and just that really our clinical engineering folks behind the scenes at the hospital are enablers and potentially sometimes the people driving those outcomes. So the top goal for this portion of the indicator project is to build an evidence-based model for clinical engineering staffing that can be stratified to not only the national level, but also the local level. We're predominantly looking at several models to address not only our high income countries, but also our low middle income countries, as well as other low resource areas. So as you all know, not every hospital is built the same. And nationally, we have quite a bit of variation in terms of scope of practice. So one of the things that we wanted to build into this model was the ability to have some autonomy and to account for those. Another sub-portion of the staffing is that we're going to look at certification and education. So in these countries, what type of education does the staff have? What type of certifications do they have? And really trying to establish minimum education certification, as well as potential recommendations for certification and education in conjunction with this staffing model. So I'm going to show you a quick screenshot and demo, and I just want to note that this is draft only. This is kind of our first initial concept of what this could look like. So please do not take this as gospel. We are still getting a lot of data together. So this is really just a working model at the moment. So again, please don't take this as gospel. So the idea of the options was to have potentially up to 3 different options for the staffing model with an algorithm to account for large hospitals. So these are likely going to be high income countries, large hospitals, very high dollar, high end equipment, and lots of equipment. The second option is really by number of devices. So this is going to be maybe a less intensive hospital or a medium to small size hospital that has a lot of pieces of equipment, but maybe doesn't have that high end equipment like a linear accelerator or CTs or MRIs, or may only have a handful of those types of devices. And then the third one is really most likely going to be for low resource areas, maybe rural, maybe low and middle income countries, that has maybe a small bed count, but a lot of ambulatory visits where people are coming to get care, and thinking through that. So essentially what we're attempting to do is create a department profile for local hospitals where you could input this data of your asset value, the number of devices you have, the number of network devices you have, since that's a growing and emerging part of our breadth and scope. So possibly also the number of resources you need that kind of have those hybrid information technology roles, as well as bed count and ambulatory visits. So the idea is that we have algorithms that create these staffing models where this would give you at a local level, once we drill down to it from the basically subnational level, that it would give you an idea of the number of staff you would need to service that particular type of hospital. And again, really we're building this data and building this information off of the evidence and the future work we're going to do, which I'm going to talk to you about in a few minutes, to really get a good recommendation for how we're going to move forward. So then moving on to more traditional indicators, we have a lot of types and importance. So one of the main things that we are doing with this is trying to determine what types of indicators are most important to us and how we want to move forward and prioritize those, again, to give us a global platform that if we were to consolidate and have these indicators, the ministries of health would be rolling these up to the World Health Organization. So again, these are going to be very important, and they're going to have to be scalable and usable and really defendable with data and analysis as we move forward. So we have a draft survey, which is honestly very much like the book of knowledge and possibly going through these. And the idea is that we would get a hospital profile, a department profile, which would pull in the staff you have and the mix as well as their credentials. And then we would really dig into indicators in several paradigms. So one would be safety. This is really going to be your PM completion, your corrective maintenance completion. Program performance would be really a whole look at how your program is performing in a wide range of items. financial performance, so how much it costs you to support your equipment versus other organizations, as well as the mix of service contracts and what the clinical engineers are doing on site. And then program maturity. So as we all grow and our programs grow with us, and as the needs of the healthcare environment change, we are being stretched into different ways of being and different things that we need to do. So thinking of a multiplier potentially in here for the additional items that some programs might be doing versus others. Another one that I talked through was interoperability and cybersecurity. So as you know, a growing and emerging part of what we're doing, as well as inventory management, how we're managing our inventory and making sure that we have an accurate count, as well as accurate preventive maintenance schedules and documentation of those, as well as any others. So there's also likely going to be other categories of indicators that we look at. So in terms of our indicator project, what are the next steps? We are working to create a white paper on current literature and available resources from peer-reviewed journals and other publications within the international context. We're evaluating our key collaborators, which hello, all of you guys are, and other key clinical engineering resources that could aid in our development of the project. And then what we want to do is create a draft survey tool that's going to kind of test on some of our collaborators. And we talked through this and had a presentation in Rome, but likely also having another discussion on this. And then what we really want to do is get the test survey data out, analyze it, and then possibly determine if there's amendments that are required. And then what we would like to do is put these surveys together, get them in front of you all, and with this data, not only collect it, but also prioritize with the IFMBE groups what's the most important. So at the end of this, what we really are looking to do is to create a report and recommendations for the HTM indicators to the World Health Organization, and not only provide this preliminary benchmarking data, but propose a potential staffing model algorithm, and then include future considerations for the indicators and research needed. So how can you help? I have included some links here, so you can go to our blog that talks all about this survey, and you can also take our survey, or currently our draft survey, so that will help us kind of polish up this tool. And then also what you can do on a continuous basis is publish your indicator data, publish your staffing data, all of the great things you're doing. Calroy is on, who is really the leader and editor behind the Journal of Clinical Engineering that IFMBE puts out. So definitely a plug for that. Make sure if you have this information, please submit it to that journal. And then also you can contribute to our indicators team and project. So with that, I'm actually going to turn it over to Luis, and I believe we'll take questions at the end.
Thank you very much, Jennifer. Well, first of all, I believe that the efforts that are being done to pursue an investigation and research regarding the topic of what should be measured and what is being measured is really important. So I really want to encourage everyone in this group and your colleagues as well, if you guys can help us out, work on those links that right now Jennifer showed, that would be amazing. We will send this presentation to all of the persons that registered in this webinar, so don't worry if you didn't catch it, it'll still be there. But first of all, I'm going to make a small pause to congratulate a Mexican hero in HTM that's here with us. Roberto Ayala, happy birthday from everyone here. And well, very good. We're going to be discussing the second part, that is, well, first we are going to produce metrics and indicators and KPIs and KRIs and performance reports, etc. So one thing is to produce those results. And the second one is, how do you communicate those results to the directors to people that actually are, let's say, more involved in the business strategy of a hospital or in the legislation part. So, and I have a really important question to everyone, and it's really a question to think about is, how many times have you felt that you've worked so hard, but you haven't been, receiving the proper, not congratulations, but the proper understanding of the value of the work that you're doing. So we as HTM practitioners, as clinical engineers, and as service engineers and technicians, you know what it's like to be in a hospital and to be there 24/7 working on everything. And it may seem that as time advances and keeps getting more challenging, you just keep doing the same thing and you don't grow. So one of the main hypotheses behind this that Jennifer and this project are trying to prove is basically through the measurement, we get an understanding of how we're accomplishing all of those goals. So we're going to talk about how to communicate effectively with stakeholders and how to engage with them, because stakeholders are people that have an impact, either positive or negative, regarding everything that we do as clinical engineering. And this is a term being used in project management, which is later defined, that I will talk about right now in a bit. So talking about project management, there is an institute in the United States that is called Project Management Institute, and the PMI describes, well, actually they're the ones that are pursuing this discipline of project management in an international basis. And basically what a project manager does is to create or modify an existing product or service that serves a purpose. Okay, so we could say that unofficially everyone here is project manager, because you guys have built processes, you guys have built a clinical engineering department, etc. And all of those things are projects, because they're focused on producing a result. And the difference between a project and an operation is that a project has a definite start and ending, while an operation can be, being done over and over again, and it's cyclical. You know the steps to do it. So that's why an operation is considered an activity that on an ongoing basis is being produced without let's say, an end date. While a project, if you want to build a house or a hospital, you know when you're going to start, and you have a deadline for you to finish. And the Project Management Institute has a book which is really important for us project managers, that is called Project Management Body of Knowledge, or the PMBOK, PMBOK. And this describes a methodology on how to build a nice project. So if you guys can log into the website of the PMI, that will be nice. And I know that CED is working on a body of knowledge, which actually focuses on producing results expected from the clinical engineering department. So this methodology relies on 10 knowledge areas, which are the ones that you see on my screen, which is scope management, time management, cost management, procurement management, stakeholder management, communications management, human resource management, quality management, risk management, and integration management. So my understanding of these 10 knowledge areas is that for any company, these are the main 10 areas that produce the biggest quantity of pains in a company. Either it is budget, or it is procurements, or it is stakeholders, etc. So it's really important for us to know that these knowledge areas, although they are knowledge areas, they're also the topics that we have to assess when building a project. And stakeholder management is a really, really important one, because stakeholders have to do with our project and get impacted positively or negatively by the result of the project. So if, let's say, we're building a clinical engineering department, we're from ground zero, we're going to start over, and we're going to find processes, etc. We have to think, who is a stakeholder in this project? Who is involved in the end result of this project? Well, practically and very much everyone in the hospital. So the board of directors or the C-suite is really involved, because clinical engineers work with the second most important asset in a hospital, which is medical equipment, after the people, of course, and the professionals are working on it. So medical equipment has to do with everyone in an institution. It has to do with the patient, of course. It has to do with who uses the device. It has to do with whoever can get involved in an adverse event, either chemical risks or biological risks, etc. So we have to think of them in advance. But what this session or this part of the session is really about is, how do I even know what they're expecting from a clinical engineer? And another question is, how do I even know they know what is a clinical engineer? So regarding stakeholder management, some activities on the clinical engineering department are projects. You have projects all the time. Either you're gonna receive, let's say, a bunch of medical equipment, or you're gonna do some HTA processes for this, etc. And now you also have operations, and it's really important that everything gets measured either with metrics and indicators. The difference between a metric and an indicator is that a metric is everything that can get measured, and an indicator is justly something that tells you how close or far you are from accomplishing an objective. So the difference between metrics and indicator is practically the focus that you give it to the measurement. So if, let's say, you wanna, you're assessing the budget, let's say in a clinical engineering department. So a metric would be maybe the number of transactions that you've created or you've accomplished with that budget. But an indicator would be the budget completion. Let's say how much money have I spent to this day? And the difference between those two measurements is that the metric of number of transactions maybe doesn't tell me much about, a specific goal that I want to reach, but the indicator of the budget completion or the amount of money that I'm spending right now actually tells me how much money have I spent from my objective of spending this determinate quantity of money. So and in indicators, we have a lot of different variables. For example, KPIs, which are key performance indicators, or key risk indicators as well. Number of adverse events, number of mean time failure between events, etc. is another one. So at the end, the metrics and the indicators have to help us visualize the current state of what we're doing regarding projects and, of course, operations. And this is really important because it maybe symbolizes like a gauge that we have to have first for us to evaluate ourselves, and second, to show the board of directors how good or bad we're doing in work, because as well, this is really important to communicate everything. So let's say the most general command chain is that we have the government and the shareholders of a hospital that have a relationship with the CEO of the company, because as CEO, this person is the leader of the rest of the areas and has a team with certain knowledges and skill sets that work either on operations, on finance, etc. So the CEO knows what the shareholders want, but also he knows, maybe he has a department regarding regulation and everything, of course, but he's responsible that the hospital is okay with everything specified on the law. Okay, so the CEO has someone on operations, okay? And this person on operations oversees everything regarding infrastructure, regarding the services, the areas, the equipment that needs to be handled there, etc. And this operations works with another areas, which are maybe the medical staffing. So, I mean, not the medical staffing per se, but with a medical service manager, with a finance manager, etc. So normally, and I say this normally because this most of the time happens, but not every time, the operations manager speaks to the head of the clinical engineering department or the head clinical engineer. Maybe there's another, let's say, immediate command chain of the head clinical engineer, but somebody has to report to someone, right? So in this case, and in this example, the operations manager is in charge of, assessing the work done by the head clinical engineer. And this head clinical engineer oversees the work of specialists, engineers, technicians, which are the ones that relate most to the medical equipment. And of course, it ends up in the patient. So this, I put this commas in the command chain, has to do with stakeholders. Each and every word you see here is a stakeholder, because everyone has to do directly or indirectly with the medical equipment being available and safe. So if we are talking about command chain, we're showing who gets taken care of by who, or who gets evaluated by who. But look at the communication process. So we have the patients that get related to the medical equipment in an indirect manner, of course, because they get either diagnosed or treated or rehabilitated with medical equipment. but the medical equipment are the ones who talk in a hypothetical way with the technicians, right? And technicians have to talk to the specialists and engineers. And the specialists and engineers have to talk to the head clinical engineer. And here's what the biggest problem is. If you're working in a clinical engineering department or in a biomedical engineering department, and the only reason that they call you is when something is wrong, or the only binary measurement that you have is when nobody tells the CEO or the operations manager that something is wrong, means that you're doing okay. Here's the biggest problem you have, and we've seen this in a lot of hospitals. We've talked to managers, operations, medical, finance, etc., and we've asked them one question. So how do you measure the performance of clinical engineering? And most of them, at least in Mexico, say, well, we measure costs, of course. We know how many we spend on medical equipment post sales or operations. And well, we measure let's say if they're doing a good job, it means that nobody's coming here to talk about it. Or if they're doing something bad, we assume that somebody, is just speaking their mind out on how the medical equipment are not working. Or if the medical equipment are not functioning, or we have a lot of downtime, etc. But there's not a lot of of a criteria of measurement, and it's really important that we help the clinical engineers and the technicians and the specialists, keep growing by measurement, and also it's really important that we have a communication process that goes from bottoms up. Okay, so the work that gets done by the operation needs to translate not in a technical language, and that's what I told you in the beginning. We need to speak the language of the manager, or we need to have a translator that helps us translate the operation from this translate the operation to a decision-making process. Okay, so it's really important that we focus on this problem, and that you actually talk with each and every one of these people and just ask them, like, what do you expect from the clinical engineering department? Is there any data that you would want to receive from us on a let's say on a recurring manner, or every 2 months or every 3 months? Like, what are these metrics that you expect to see? Do you want to see costs, but not in a whole? Like, you want to see costs regarding, let's say, spending on accessories, or spending on let's say parts, etc. So you want to see it by brand, you want to see it by provider, etc. So this is where the magic starts happening, because the manager starts seeing the value of someone having let's say a management skill set of everything that needs to be done for the metrics to come up. So this communication process is really interesting, and we have to just talk about this myth that no news is good news. Okay, so we've talked to many managers before in the past, and just asked them, like, how's your clinical engineering department working? Like, are you satisfied? And there's this way of saying it in Spanish, which I'm not gonna do because it's it's really funny, but in English it's basically, well, nobody has come here to to talk crap about the clinical engineering department, so I assume everything's fine. So no news is good news. But there's much more than just like knowing that if somebody talks bad about the clinical engineering department, this is going bad. Like, we need results, we need measurements, and as Jennifer said, like staffing, like mean time between failures. Like, there's where the research and the richest information is on the metrics, because Lord Kelvin said, what doesn't get measured won't ever improve, because it degrades every time. And this is so true even with our own budget. Let's say we earn money on a monthly basis, and if we don't measure on what we're spending, we're never going to improve, because we're never going to detect those faucets that need to be closed or adjusted in order for us to represent a better result. So at least my hypothesis, and this would be a really interesting discussion with the group after the presentation is over. So why is the reason that the clinical engineering department is always on the basement, that there's no money to buy simulators and analyzers of medical equipment? And basically it's one of either two. At least this is my personal opinion. One, either the managers or directors don't know how to measure the performance of the clinical engineering department, and for instance, they don't know how much value included in that department. So that's one, and two is basically because they don't care. There's this book that was written by some of the CED members regarding clinical engineering. I can't remember the name now, but it's edited by Ernesto Yadanza. It's called Clinical Engineering, I guess. It's a white book. I'll send you the link on Amazon. And there's a really nice article that says, you know, the number of clinical engineers in a hospital is directly proportionate on the interest of the institution or healthcare system on these topics. And they mention regulation, patient safety, budget optimization, etc. So 4 or 5 criteria. And it's really important to see how it is true. Like if they don't care about, you know, saving money and saving lives, or they care but not as much through technology, of course, they're never going to hire more clinical engineers. And that's, you know, that's a fact. Like if they don't know how to measure it, they won't understand it. So we end up in the same phrase, you know, said by Lord Kelvin and then by Peter Drucker and some other authors regarding management skill set. So first of all, it's really important what Jennifer said at you know, when she showed this draft is every company is different. And, you know, a hospital is a company, and it is a company. It doesn't matter if it's private or public. It is a company because it has to administrate a certain amount of money in order for it to survive. So it is a company. Maybe it doesn't sell anything, talking about governments, but it has to, you know, analyze and assess everything that comes from income and outcome. So it is a company. And this company has to be, you know, a feasible business for it to be, you know, working the years to come. So it's really important for us to assume and understand that every company is different and does things differently. But at the end, maybe the goal will be the same, which is bringing patient safety, helping people get better, and being a feasible and really reliable business. So talking about stakeholders in this company that's called a hospital or a clinic. You know, according to PMI, these stakeholders are people that get impacted either positive or negatively by the results of the project. They have interest in the project, and they also work with the project manager, which is the leader or the person responsible or attainable of producing this result. And the stakeholders can be the project manager, the project sponsor, providers, project team, customer, and other involved departments, etc., which translate, of course, to these people right here that we were talking about earlier. The government is a stakeholder because, you know, if our project or our operations do not meet the criteria established by the government, we have a huge problem. And the results of this project or operation may not be, you know, as good as we thought they were going to be. The shareholders are stakeholders as well because it's their money, which is there. And of course, they want to be producing a certain amount of money or objectives each and every term, right? So the CEO is a stakeholder because he's the leader of leaders. The financial medical operations manager are also, because medical equipment is related to finance, to the medical director, to the operations as well. So they are also stakeholders. The head of a clinical engineer maybe is a project management, the specialists, the engineers, etc. And of course the patients, because the well-being of medical equipment and medical devices ends up in a patient. So they are the most important stakeholders, not because they're involved in a project, but because of the end result can be a catastrophe for them. So this is the main definition of a stakeholder. And now we're going to talk about how to engage them. But first of all, we need to learn that if we are not talking to these people, to these professionals, and understanding what their needs are and understanding what are they expecting from the clinical engineering department, we're not going to get it anywhere. And this is one of the main reasons CED is doing a great effort to talking to stakeholders and also the wider public, because we want to know if they know what a clinical engineer is, I'm sorry. And also we want to know as well as how to make them understand that our value comes from assuring that the medical equipment works the way it's supposed to be, that the service companies are, you know, prepared to do XCA, Y, etc. So that everything works towards the same goal, which is making devices available to assess patients in a safe and reliable manner. So not talking to them is a huge problem. So if I could leave anything here on the table with you guys, is talk with your stakeholders and ask them questions, basic questions like, what do you know about clinical engineering? How would you measure the efforts of the clinical engineer? One time I did this this exercise where I went to 10 pharmacies in Mexico, which have, you know, responsible medical doctor that does, you know, just first attention diagnosis. And of course, when you get to the place and you get diagnosed, you know, you get measured your vital signs. So I asked a question to 10 people, and when they were measuring my blood pressure, it's like, hey doctor, like I want to ask you like one simple question. And of course they didn't know I was a biomedical engineer. And asked them, when was the last time you, like, this is the medical equipment, right? Yeah. So when was the last time you serviced this, you know, this piece of equipment or calibrated, or like, does this thing like need calibration at all? And they were just like, no, well, I bought this like 5 years ago and I've never done anything because, you know, it doesn't need calibration. I'm like, oh, okay. So that's when I took my hat of clinical engineer and I told them, like, all right, so this is a piece of measurement. It gets worn with time and with, you know, conditions and metrology uncertainty, and et cetera. So maybe you've diagnosed somebody of hypertension when, you know, the hypertense was the equipment, not the patient. So not talking to them and letting them know what we do and why it matters is a huge problem. And I'm going to leave you with 4 process groups that are related. This is taking directly from the project management body of knowledge on stakeholder management, and I adopted it to clinical engineering. So first of all, we need to identify who these stakeholders are. Second, we need to plan how we're going to manage these stakeholders. And third, we need to manage their engagement in what we're doing. And number 4, we need to control these engagements, okay? So these are the 4 main areas that we're going to focus, and we're going to talk about the first one on identifying stakeholders. So how do I identify them? So first of all, we need to get a small piece of paper or open a spreadsheet or open Word and just make a list of all the stakeholders that we think might be involved in the clinical engineering process. So we know that we do inventory management, that we do maintenance management, et cetera. So we need to do a list of these stakeholders, all right? So we're gonna create this directory and we're gonna include some important information such as where to contact them, what is their, you know, their position, if they are, you know, accessible people or they're, you know, more serious people, like we don't know, maybe their character's a little bit tough, but also maybe just include their birthday to maybe break a little bit the ice on their birthday, and just like, you know, maybe a postcard or maybe a cupcake or maybe, you know, a small detail will make the difference on opening doors for you in the project. Because you have to know that in any project, you need to be an excellent negotiator. You need to convince people to, you know, to give you resources, to give you time, to give you interest, let's say, in the project or what you're doing. So these small details do matter. And third, go to each of them and, you know, tell them what you're doing. Tell them that you're doing this directory of stakeholders because you want to keep everyone on the loop on what the clinical engineering department is doing. And ask them if they think that there's somebody else that should be included and why. Like maybe the operations manager will tell you, oh, have you talked to this person? And then maybe you haven't. And that's, you know, maybe a key person that you didn't know was involved in a process that is a result of one of your processes. So this is really important. So just talk to them and ask them if there's anyone else you should be talking to. Number 2, so we've identified all the stakeholders in our projects and operations. So number 2 is the really important stuff where you have to break the ice. So you need to plan a meeting with each stakeholder, a 10-minute, 15-minute meeting, where you explain to them what a clinical engineer does. Okay, so maybe you can have some material prepared, maybe a piece of paper, or maybe something that you printed out on what is clinical engineering. I know that the CED website includes a great variety of material on what clinical engineering, how clinical engineering helps every healthcare institution. So maybe just prepare some material for them to read on their own time. And, you know, just take a moment to explain to them, all right, so these are the main processes that we're involved in. So inventory, maintenance, training, HTA, etc. And just let them know how your activities relate to theirs, all right? So regarding the profile, maybe you're talking to a patient, or maybe you're talking to the general manager. So just let them know that how, maybe you don't even know how they relate. So just ask them, like, how would you relate what I'm doing to your work? And then it's really important for you to ask them, why do, like, if any of these clinical engineering processes, if something goes wrong, which process would concern them the most, okay, and why? So maybe the medical service manager says, like, all right, so if any piece of equipment is not working, like, that concerns me because I will want to know. So, okay, I need to keep him in the loop, maybe not every time there's a failure, but let's say every time there's a high cost equipment that fails, because that would maybe mean that what we're doing, like if the equipment is failing, maybe there's a whole area that is not working. So that impacts both on diagnosis or treatment and on income. So it's really important to understand which of these processes concerns them and why. So then just asking them an open question, like, what are your expectations of the clinical engineering department? Like, what is your wish list or your Santa Claus list, or the things that we will have to meet in order for you to be, you know, talking good things about us, okay? So then ask them also, as well, like, is there any measurements that we need to have delivered to you, and on what frequency? Maybe they want to report every 3 months or every 6 months regarding performance, or regarding, you know, service tickets. Every time a person calls the clinical engineering department, like, I want to know how many times they call you a month, and I want to know, like, what percentage of those times that they called you ended up being a real failure. Because, you know, there's a big sport in hospitals of you know, people, doctors and nurses, you know, calling the clinical engineering department and letting them know that there's urgent matter to be assessed. And then when you get to the ER after 15-minute, you know, jog from hospital to, like, from place to place, and then changing to go into the OR, etc. Like, you just see the cable not being plugged into the wall, or you see, you know, medical equipment not being turned on. So that is timing at the end, and that's timing that, you know, if you had the time of the world, like, of course, there's no problem, because you're there to, you know, assist in a technical manner. But what's really important is what you're doing with the time. You know, I have this saying that the most important resource in this world is money. It's not money, it's time. So time is the most important resource, because what you do with that time gets an impact on each and every one of those expectations and goals that you have. So what you do with your time is gold. It's even more gold than your money. So it's really important that you take your time on a daily basis seriously, and by analysis and measurement, let's say 1 out of 10 times that they call me, like, there's really a problem with that. So if I measure that and I host a small training session, you know, just focus on that problem, maybe I can, you know, reduce the number of times that they call me. But that's not possible if I don't measure that again. So, you know, build a stakeholder profile with this information, and just, like, do a small draft of, you know, who this person is, what they like, how would they like to be informed, etc. And well, it's really important for you to manage these stakeholders through those results and through those metrics. So keep them involved, send them a report, send them a small email, like, do a minimum viable product of this, and just start testing out how everything, you know, just keeps working. Number 3 is, how do we manage their engagement? Okay, so first of all, you have to stand by your word. So if you say you're going to send a report the 30th or the 31st, you need to send it that day. And if you can send it before, even better. So by being responsible and being a professional and delivering good and productive results. Also, we had one time a mentor said that the only thing that he expected from us is to inform him when there are bad news. So not to, you know, just put a little sugar on the coffee before to speaking of bad news, just like say them the way that they need to be said and in the time they need to be said. So don't hide anything. And that's how you're going to keep stakeholders engaged, you know, just being clear, being informative, being professional. And also, you know, just regarding communication, just remember that that profile that you wrote on the previous step is really important to understand how you're going to win this stakeholder over. Okay. And number 4 is how do you control stakeholder engagement? Okay. So just meet them on a regular basis, ask them for feedback. And if they're not really involved, you need to find a way to persuade these stakeholders. And also you need to know that it's really difficult as well to assess stakeholders regarding their personalities, thoughts, etc. So the conclusion on this nice session is that there's a binary way of measuring, results, which is a practical sport right now among hospital managers, and we need to change that. So if we measure things and communicate them in a way that they will understand, I think, and as well as Jennifer was telling a moment ago, like, they will understand the value of what we're doing. So CE performance evaluation is not taught in management schools, and it's not taught in clinical engineering, at least in Latin America. And this is something we need to start learning now, not only project management, but also stakeholder management. Like how do we measure results and how do we deliver them? Also measure only what matters to a project and to stakeholders. Avoid those vanity metrics, which are metrics that sound really nice, but just don't help in anything. And last but not least, communicating metrics is as important as producing them. So don't focus on building a nice report with cool presentation and everything, but also focus on what communication brings you. And well, folks, we invite you to get in touch with us. This is the first session of the webinar series. We will be having a minimum of one per month. Next month, we're going to be talking about metrology. Almer from Bosnia and Herzegovina, which is a CED collaborator, is going to join us to talk about the aspects of metrology. And please, if you have any doubts, any suggestions of topics, please let us know through each of these channels. We will send you this presentation, and the recording will be available as well. And don't forget to keep in touch, and also to invite your colleagues over to these webinars. On our behalf, this is everything. We hope you've enjoyed this webinar as well as we enjoyed preparing it and talking to you about it. And Jennifer, I don't know if you have any closing comments regarding what we're doing here before closing the session.
Thank you, Luis. Thanks so much for all of that information on stakeholder management. I think really helpful, and I took a lot home from that as well. Again, I just wanted to echo the thanks for your participation in this, and I hope we see all of you on our upcoming webinars. I didn't know we're right up against our hour, if we wanted to take some questions, Luis, or if you would rather have people kind of write them in and maybe we can publish those out.
I think that would be better because we have 2 or 3 minutes left. So if
okay, perfect.
If you guys could maybe write them down and send them to us in the email that we're going to send you, that would be really nice. And maybe we could do another session with questions and answers regarding this topic.
Perfect. And I think that'll be great to publish on the IFMBE site as well.
Sure. Great. Tom, any closing comments?
Wonderful job, both of you. Thanks so much. And as you heard, February metrology, and then March through December this year, we're going to take off the 10 competencies one at a time and really talk about a little bit describing these 10 competencies that many of you seen, and let us know if you haven't, we'll get them to you. And talking briefly, describing them, but really getting into field-based examples of how they work out in real life in your world, and talk about the leadership aspects of those competencies, unique competencies in clinical engineering. So thanks, everybody. Have a great day.
Have a great day, everyone. Don't forget to keep in touch, and we'll send you the recording and materials whenever they're ready, today or tomorrow. Have a great day.
Thank you.